Perfect. Okay.
Okay.
So the purpose of tonight's meeting is to try and give everybody a bit of an orientation for our mock competency coming up on Wednesday, Thursday, and Friday of this week. And I put together a small PowerPoint presentation to give you an idea. Dr. Gurin's calling me. Hang on. Hello? You can't hear me? Share audio. Can you hear me now? Hello? People said they can you hear me? Hello?
Yeah, I can hear my.
Yeah, I can hear you on the phone.
Okay. Okay.
So,
Well, we're going to go forward.
yeah, we can hear you then, sir, and I can hear Dr. Markowski.
Okay. So we'll try and give an orientation to the mock that's coming up on Wednesday, Thursday, and Friday. I would like to go over some policies and just some the way we're going to run this program and give you some of the ideas of how we'll be grading you, as well as what lesions might qualify. If you have any questions at any point, please bring them up. It's a little bit hard for me to know about what pace to go through. So I will, I have a number of slides I'd like to share with you. The first one just simply says that this is in your syllabus, that we must have a mock competency that's actually a UDM competency for the Class 2 and Class 3, and it is participation in this is mandatory. By passing this competency, you will become eligible to take the CDCA examination. If you are not successful, in most instances, we'll have to determine a remediation before you will be allowed to challenge the exam again, and you'd get a score of 70 if you're successful the next time around. Okay. During the exam itself, there will be no faculty assistance at all. And this year, because of COVID primarily, we've lowered the number of surfaces to 40 rather than 75 to be allowed to take this examination. Primarily, again, the purpose is that it is a UDM competency exam, and in most cases, the policies and the procedures of the exam are very, very similar to that of the CDCA exam. However, in any instance where there's a conflict between our school policies and their policies, our policies will actually prevail. And probably the single best example I can think of is that the CDCA manual says that if you choose to use a bevel on a Class 3, the bevel can be no greater than 1 millimeter in width. And in our school, on a Class 3, you are required to have a bevel. So for this competency, on your Class 3, you must have a bevel, and it certainly can be greater than 1 millimeter in width. Okay, so besides the actual process itself of the Class 2 and the Class 3, the floor examiners and the evaluators will be looking at your clinical judgment, professional conduct, case selection, your tooth isolation, infection control, pain management, and patient management. The exam components themselves are a Class 2 preparation and restoration and a Class 3 composite preparation and restoration. For the Class 2, you can do a traditional amalgam. You can do an amalgam preparation and place a composite, or you can actually place a composite slot preparation. Okay, the workflow of the exam, this is important and a little bit different than what you might be used to. So the start check is just like any other time your patient would be examined. We want to make sure that the vitals are good and that you have current x-rays and that this is actually in the treatment plan, all of the things that you would normally do to get a start check. The next check that you would do is called outline form, where you're showing us the ideal preparation. And that's not a step that we always do in the clinic, but in this instance, we're asking you to refer back to what you learned up in the sim lab and give us the ideal preparation, the ideal dimensions of the preparation. It doesn't mean that all the caries is out, nor does it mean that if there was an existing restoration, you may not have removed all of the existing restoration, but we would like to see what would be the minimal preparation according to the dimensions that you learned up in the sim lab. Once you get that checked, your next step, if it was, you know, a small amount of decay and there was not an existing restoration, probably the outline form would be the same as the preparation form. If there's a discrepancy between the two, you may need to ask for modifications, meaning that after you give us the ideal outline form, perhaps there's still caries on the axial pulpal wall. If that were the case, and you thought that you were going to have to remove a substantial amount of the axial pulpal wall to remove all of the caries, you would ask for modification. You may ask for one or more than one modification. Ultimately, after you've asked for modifications and those have been checked, you should be ready for your preparation check. And once you've completed that, you'd be ready. This is a little bit out of sequence. You would be ready to start your restoration. And there's no check until the restoration is completed. And once you've completed the restoration, you would self-evaluate, and then you'd call for the restoration check. Once that's completed, you would dismiss the patient. And if you're doing two different procedures, you'd start all over again, asking for the start check for the second procedure that you're completing. Okay. As I said earlier, the start check, we would look at the medical history. We'd look at your x-rays. We might want to consider the patient's caries activity, particularly if maybe you had a DO and there was a very incipient lesion on the mesial, as to determining whether or not that should be part of your treatment plan. You should have, we would do both a clinical and a radiographic evaluation. And we want to be sure that the treatment that you're rendering is in the patient's treatment plan and you're treating in proper sequence. Faculty does have the right to reject the proposed treatment, even if it is part of the treatment plan when deemed, if they think it's inappropriate. If you probably would have the right to discuss that with the faculty before, you know, if there was a difference of opinion. As in the patient exam for the CDCA, they allow you both, you know, if your first lesion presented is rejected, you will be given the opportunity to present a second lesion, either on that same patient, if that applies, or on a different patient. In this instance, we're doing this a little bit differently. If your first lesion was that you presented was rejected, you would still have the opportunity to present a second one, but we would deem that the first one as a failure, and you would, if the second one was accepted, you would go ahead, and if you passed everything, the score would be recorded as a 70. And our reason for that is that in this competency, one of the things we're looking at is just your skills in case selection. So that is a difference between us and the CDCA. But in the COVID environment, CDCA is using their Compidon tooth, so there really wouldn't be a patient, a live patient. For your start check, if you're doing a class 2, you need to have both a bite wing and a periapical radiograph. In their exam, that would be less than 1 year old. We're allowing it to be up to 2 years old. And for the class 3, you just need a periapical. This is not a radiographic examination, but certainly for the, on a class 3, if you were doing number 8 ml and it didn't show all of the distal of 8, that probably would not be a problem. But on the class 2, because they have different rules, and one of the rules is for the class 2, at the end of your procedure, when you've finished restoring that tooth, there can be no caries on that tooth anywhere. Whereas in the class 3, their policy is that if you did the mesiolingual, there could be caries on the distal. I think they developed that policy years ago because the class 3s were harder to come by, and you could share those cases. But in our instance, we're allowing you to have 2-year-old X-rays, and but if on the class 2, we do need to be able to see both proximal surfaces. Does anybody have any questions up to this point?
Yes, Dr. Stewart, there were a few questions I think we're answering on the chat. Sorry, I was not hearing you at all, so I signed in again.
Okay.
Thank you for doing this. Just the question was whether they could take an X-ray on the day off or whether the PCCs will be around to get the treatment plan if it's not treatment planned. Our preference for you to start right on time is just to have everything already previously treatment planned and approved, obviously. But if you have, maybe few students may have the case that the patient has not signed it yet, we just want to make sure that you don't start any case unless the treatment plan is approved. And we can get that done at that time, but obviously with the preference for you to select cases from your patient pool that are already being approved. Hopefully you have that.
Yes, and there certainly will be the exam. The start time of the exam is 9 a.m. and there will be faculty on the floor starting at 8:30. So if you bring somebody in early, you can certainly take a radiograph then. And if, sometimes during the conduct of the exam itself, the examiners might want you to take a new X-ray, and they have the right to do that. And certainly we would like you to take the necessary X-ray if they ask for it. Okay. Another way. Oh, sure.
About the case selections, we are getting a lot of questions, but Dr. Stewart is going to go over what the criteria is, what happens, how you need to manage if there's a pulpal exposure and stuff like that. All right, he's going to get there later on.
Okay. Besides radiographically, we can inspect the tooth visually, and you can certainly use transillumination to demonstrate a lesion. So those are a couple of other ways that you can gain approval for your proposed treatment. Obviously, we're going to look at blood pressure. You need a medical clearance. And certainly if there's somebody underage, you have to be sure that the parent or guardian is in our building. Just going back to the outline form, because that's a term that you're probably not all that familiar with. Let me just read it. This check requires the exam candidate to prepare the ideal cavity preparation. Caries is minimal. As I said earlier, the ideal outline form and the final preparation may be the same. In many instances for this check, caries and or existing restorative material may still be present. If you go to Blackboard and under this Integrated Patient Care 4 course, in the syllabus, you'll see the specifications for the Class 2 and the Class 3 preparation and restoration. So you might want to review that, because that would give you an idea of what the ideal or outline form is. But I think you know that anyhow. So the outline form needs to be checked. The faculty needs to be called over to look at that. And after they've completed that check, you would move on to doing whatever is necessary to continue preparing the tooth for the final prep check. So that means once you have your preparation check, that's saying that all of the caries is out, you have your enamel supported by sound dentin, and you're ready to go ahead and restore that tooth. So as far as time goes, the exam starts at 9 a.m. and ends at 4 p.m. That's 7 hours, just like the actual CDCA exam. If you were doing two treatments, you would be allowed 7 hours. Okay, if you're doing one treatment, the maximum allowable time for that one treatment is 4 hours. Now, there's a little bit of a trick here, in the sense that if you were doing two different treatments, you could conceivably allow 5 hours and 15 minutes for the first one and allow yourself an hour and 45 minutes for the second one. What has happened in several instances over the years is that you went over the 4-hour treatment time for the first patient and then your second patient didn't show up, you would only have been allocated 4 hours. So let's say you actually spent 4.5 hours on that, and you would have then had 2.5 hours to complete the second treatment. But since you went over a half hour, they would actually fail you for the first one. As far as, so you want to watch your time. You're allowed to take breaks at any point. You can take lunch if you want to, but the exam clock really doesn't stop. Okay, prior to the 9 o'clock start time, you can certainly be in the clinic setting up everything, and hopefully you can actually call faculty over before 9 o'clock. They can evaluate everything, but you can't actually administer anesthesia or start the hand pieces until 9 a.m. Okay, so again, this is just saying that you have the full 7 hours if you're doing 2, but in any instance, if you cannot start the second one if there's less than 1 3/4 hours left before the exam would end. Okay, and the way we're looking at it is that you have 1 hour. You have 45 minutes before the exam ends. You must have the preparation check, and the patient must be ready to have the restoration evaluated by 4 p.m., assuming that you have not allocated less than 1 hour and 45 minutes to that patient. Okay, this just says the same thing again. So you could, if somebody was doing just one procedure, you could start at 11 or 12. Okay, and we would start the time clock then, but if you're doing that one, if you started at 11, you'd have to be done by 3 o'clock. Okay, and the start check has to be an axiom. We have turned off the timestamp function so that you can get a start check at any point during the course of the day. Unlike, but the patient that you're treating should be scheduled in axiom on the day that you're treating. One of the rules we require is if you're doing two treatments on the same patient, you must restore the first treatment before you can start the second one. You can't have 2 preps open at the same time. All treatment must be completed under rubber dam. If you don't have a rubber dam, that would be an automatic failure of the examination. And basically, once you get the start check, you're being authorized to administer up to 2 full carpules of anesthetic. If you find that the patient needs more, then you have to request the permission to administer a 3rd carpule. As far as caries goes, we presume that if you're treating that, we're presuming that the caries extends to the DEJ. The general consensus is that on a digital radiograph, if you can see caries more than 50% through the enamel, it's presumed that the caries is to the DEJ. If for some instance you were using a film to demonstrate the caries, which sometimes we use for patients who are being brought in for the actual CDCA exam, the caries must demonstrate 75% through the enamel. For class 2s, the tooth must be in contact with the opposing arch, and we're expecting that to be a cusp to fossa relationship. The contact does not have to be on your restoration, but it has to have a cusp to fossa relationship and contact with the opposing arch. You would check that with shim stock. For the class 2, for the class 3, this is there is no requirement that the tooth be in contact with the opposing tooth in the opposite arch. Okay. At the completion of treatment, we would expect that there be contact between your restoration and the adjacent, the tooth you treated and the adjacent tooth. So if there's a slightly visually open, we're going to allow you to treat that tooth as long as you can close the contact. It has to be closed, and you have to have normal physiological contour at the end. Okay, so what we're really trying to say is that if if it was open and then at the end of the exam you were still open, you can't turn around and say, well, I should pass because it was open when it started. Okay, and again, same rules. The differences in the rules for the class 3, you don't have to have occlusal contact with the opposing arch. No carries on the class 2, but there can be carries on the class 3 lesion, just not on the surfaces you were treating. And again, we're going to allow you, if it's visually open but you can close it, we're going to allow that. As long as you can close it in, it has to be physiologically contoured. Okay, for lesions to be accepted, obviously you may not treat a non-vital tooth for this exam. No teeth with facial veneers, and class 3 or greater mobility would not be acceptable. In requesting modifications, again, that is a situation where you're going to prepare the tooth beyond ideal dimensions. And we have a form that we'll show you that we've developed for the purposes of this exam. And there are 4 questions that you must answer when you're asking for a modification. 4 questions are, what are you asking for? Okay, I want an example. You want to modify the distal proximal box. Okay, where are you requesting the modification? I want to extend the axial pulpal wall of the distal proximal box. How much are you asking for? Are you asking, basically, we tend to think of modification requests in the range of about 1/2 millimeter. I think that it would be excessive to be asking for a 2 millimeter modification, and I don't think you should be asking for, a 1/10 of a millimeter either. And why are you requesting this modification? Because there's caries. And a word of caution on this is you need to be very, very specific about what modification you're asking for, because that's what they're going to evaluate. And one of the things that's happened over the years is that somebody misspeaks in writing. They misstate the modification they're asking for, that they wanted to extend in the distal proximal box, they wanted to extend the buccal flare wall because there was caries. But in actuality, the caries was on the gingival seat, or perhaps the caries was on the axial pulpal wall, and they misstated it and said that it was on the buccal flare wall. So the modification got rejected. And so if the modification is rejected, you shouldn't necessarily conclude that you're ready for the preparation check. It may be that you asked for the wrong modification. So we had somebody who thought there was caries. They asked for the modification, but they didn't state the exact location of where it was, got rejected. So they concluded that the examiners felt that there was no caries in the tooth. Unfortunately, they sent it in for preparation check and they failed the exam because of it, because they asked for the wrong modification. So you want to be very, very careful about that. Okay. Other modifications, you could ask for a modification to do an indirect pulp cap or a direct pulp cap. Okay. But you have to be able to manage that. And particularly if you're doing a direct pulp cap, clearly you had to have the rubber dam on, and which you have to have anyway. And you have to be able to control the hemorrhage. So we're really basically talking about a pinpoint exposure. And I think that as a recommendation, I'd like you to check very carefully, because oftentimes there's an unrecognized exposure and you want to know about that before you send it in. So what happens is that if you ask for a modification because there was caries and it started getting deeper, and you ask for another modification and it got deeper and there was still caries, you're going to have to make a decision. Should I continue? Maybe I should ask for an indirect pulp cap. Or if you've done everything right, all these modifications were granted and then it did expose, as long as you manage it, it could continue. You could still be successful. Now, Dr. Gurin has developed an electronic modification request form. So you need to bring your laptop into the cubicle and fill that out. And we're going to show you that form right now. Okay, so here's the modification request form. You start out, you're giving the chart number, the tooth number, You'll indicate the surfaces that you're working on, and then you answer the 4 questions, okay? The faculty will turn around and say it was granted or not granted. There's an opportunity to ask for additional modification. Do you want a second modification? And then you go through that all over again. As you can see, okay? And do you require, okay.
Can you go back for 1 second? Let me make a comment here. Quick.
Is this the one you want, Dr. Gurin?
Yes. So this form, you have to access it. We'll put the form for you to access it from the website, course website. I just want to make sure that once the modification is approved or granted or not granted by the faculty, we have to send it as an email receipt. In other words, this is the faculty has to click, and we'll orient them to, but make sure that you receive an email once it's submitted. And then you have to open that email and leave it at the cubicle so that the evaluator faculty will come and check what type of modification you requested, and then evaluate your prep accordingly. All right, so if you keep going, once it's submitted, it's going to be filled out by you. When the faculty comes, they're going to take a look at it, granted or not granted. If you don't have any other modifications, then we have to submit it, but make sure to check that box or remind your faculty, as much as we'll tell the faculty also, so that you get a email receipt. You get an email, and that email is going to stay on your screen for faculty to check.
Okay.
And there was one question in between. At the real exam, how much points are deducted if the modifications are unreasonable or not granted?
They've in the real exam, they've never told us the actual point deduction, but basically what they're, if you've asked for a modification and they reject it, it's a very, very minimal point reduction. Where they give you a hard time is when you've asked for a number of modifications and they think that you're basically trying to get them to tell you that all of the carries is out. But you're not going to get hurt at all by asking, making a legitimate request for a modification, and just one rejection would not be terrible at all. Yes. All right. I hope that answers that.
Yes.
Okay. Is there anything else on this form, Dr. Gurin, that they need to see?
If you go back 1 second, so this will be the email that you will receive from Microsoft Forms, and then when you click on my Weave response, now you can go to the next one. Next slide. This will show up on your form, on your screen, I should say. Everything is approved, and at the end, faculty granted. So in this case, faculty granted 1 millimeter extension of the pulpal floor due to caries activity, let's say, pulpally. So once the faculty sees this, they will evaluate your prep accordingly. Yeah, that's about it.
Okay, good. So again, I'd like you to go back to your the course syllabus, okay, Integrated Patient Care 4. Again, this is the reference so that you can look at the criterion for the preparation and restoration. You may, if you wish, I know we're trying to limit, we don't want to have a lot of paper on the floor, but for the most part, most of, what we call standard not met, they call critically deficient error. But it's basically the same. Either you're at goal, clinically acceptable, or standard not met. And it's a standard not met or critically deficient in their terms where you failed something. As far as
there's a lot of questions coming up. Do you want to answer them? Because even though you're talking, there's a lot of questions, Dr. Gurin. Do you want to answer them?
Yes, I'll try to.
Repeated right after the carious lesions close to the pulp. Can we ask for a modification to continue removing the caries at the same time they're requesting for direct or indirect pulp cap? My concern is if you see that's close to the pulp, I'm not sure if I would use that lesion because you're putting yourself in jeopardy. I mean, when you're talking about a pulp capping is when you want to have a affected dentin, not an infected dentin, but also the fact that it's pulp capping is when you get too close to the pulp, but you did not see that coming. I mean, if you see it that it's close to the pulp, I'm not sure if I would choose that lesion. Just heads up. I mean, you could, but the thing is, when you call it pinpoint exposure, if you have a pinpoint exposure, you can do a pulp cap and it's not bleeding. But if you have a pinpoint exposure and you're getting bleeding and bleeding and bleeding, pulp capping is not going to work. So if it's close to the pulp, be careful with that one.
Yes, I agree with you. I mean, what's the reason for pulp exposure? Was it caries or was it iatrogenic? So we gotta make sure that we separate those, and then most likely you wouldn't pick a case that's so close to the pulp. But if you need to manage it, you ask for a request, and then you're going to be able to manage it just like it's a regular case on the clinic floor. What would you do? So this is a competency. We're actually checking to see if you can manage this patient regardless how deep the caries goes. But again, it's an exam to, if you have selected cases that are relatively reasonable, not too far extended, would be on your benefit, so that you don't have to deal with those kind of things actually at the exam format. This is just to make sure you can restore it.
There's Allison asks, is that if you had an open contact, can you drill out the restoration restore before getting the final check? That can happen in the board. They break a restoration and they're doing a bite, and you need to take it out and do a restoration, replacement of the restoration, so you can go in there. I'm going to tell you, it's going to be really hard with a composite to drill it out and do it. Amalgam is much easier. But yes, you need to restore the contact before you send it in. And Lucas says, can you plan to do a 3-surface posterior class 2 MOD right off the bat, or do you have to start at the 2-surface? If you already know you have a 3-surface, go for the 3-surface. If you start with the 2-surface and all of a sudden you see something unusual that takes you to 3-surface, that's acceptable. But if you really see that you have a 3-surface, why do you start with the 2? Go for the 3. But you have to make the decision. This is called critical thinking, and you have to make that decision when you bring the patient in. So
technically, it should have been planned, treatment plan accordingly.
Right. So
I have questions, but I'll let Dr. Stewart continue. And then towards the end, if he didn't answer or touch up any areas, I'll try to answer all the questions.
Okay. And for purposes of the actual CDCA exam, if you had asked to do a 2-surface restoration and then you deemed that it needed to be a 3-surface restoration, you would have to ask that as a modification request. Otherwise, if you went ahead and if you asked to do a DO and then you ended up giving them an MOD, that would be a failure. Likewise, if you're class 3, they would allow you to start out at class 3 on an anterior tooth if it needed to become a class 4 because you had to take away the incisal angle. Before you did that, you have to request that modification. Even if it was necessary and you did a beautiful job without having permission first by virtue of the modification request, that would be an automatic failure. How would they know that you didn't over prepare the tooth? Okay, that's the modification allows us to know that there was no over preparation. You found something that you wouldn't have anticipated. It looked like a small area of caries that met all the criterion. So you thought you were going to give, as Dr. Kashani was saying, pretty much a very conservative preparation. You opened it up and you found a lot more caries than was shown radiographically, and that's why you're much deeper than beyond the ideal dimensions. Okay, does that make sense? Good. Again, I was saying, as we said earlier, anytime there's a conflict between UDM policy and the CDCA criterion, our policies will prevail. As far as normally during the CDCA examination, especially when it's a patient examination, the patient is brought by a runner from the cubicle where you're treating over to the evaluation station, which in the past has traditionally been in the pedo area. in this COVID environment, we've made a decision that we are going to do all evaluation of your patients in the cubicle. So what's going to happen is that the way we've set up, you basically will not have faculty from your group evaluating you. So that will help preserve some anonymity. Obviously, they will still be able to see who, they'll see who is actually, treating the patient, but unlikely that they know you very well. And the faculty, we're asking the faculty to be as objective as possible. We do want you to know that this is a big difference between the conduct of this exam because of COVID and how it's normally run. So what's going to happen is whenever a check is needed, you're going to have your DS3 partner go to the people who are designated as CFEs, which are clinical floor examiners. In this instance, we've designated the periodontists who are in the given groups to be the CFEs. So the way it's going to work is that in each clinic, there will be two clinical floor examiners, two periodontists in the red clinic, two periodontists in the blue clinic, and they will be responsible for half of the clinic. So the first half, whatever it is, chairs 1 through 20, something like that, or 22, they'll be responsible for. And then there'll be a couple of teams of faculty evaluating. So your DS3 goes to the clinical floor examiner and said, in cubicle number 6, we need the outline form check. They'll write that down, and then they will dispatch the 2 faculty over to your cubicle. When they come over, we're going to ask you to leave the cubicle. You can be nearby, that's okay. And 1 faculty will do all of the evaluation. They won't talk to the second faculty. The second faculty will come in and again evaluate everything. After both have rendered their decision, they'll talk. If they both agree that it passes, you move forward. If one says it's, I think there's still caries, and the other one says, no, I think it's caries free, then there's a person designated in each clinic, basically the chief examiner. That'll be myself and Dr. Patel, and we'll come over and break the tie. And then so it'll be 2 to 1, and that whatever decision is made, that will allow you to continue, or that would end the competency part of the treatment. You're going to finish treatment that day, though, whether you've passed or not. Okay. So please bear with us on this. Give us a little room, and please, don't get overly nervous if we spend a lot of time, because we want to make sure that we are making the right call on any step that you've asked us for be evaluated. And like I said, in this, nobody's going to discuss the assessment until after both have looked at it. Okay. At the completion of the exam, before you dismiss the patient, let's make sure that everything is evaluated, okay? I don't want the patient to be dismissed and then we figure out that we don't have a grade for something. Complete your note and code in Axiom, and you can take the patient to financial for checkout. There is no fee to the patient for the services, but we want to have the patient checked out. One other thing that I didn't mention earlier is that for each cubicle, there'll be something called a cubicle card, and you'll just hang that. It'll be in a plastic folder, and we'll be able to put the time that you started, the time that you received the outline form check, the prep check, all of those kinds of things, so that we can verify that nobody's gone over on their time and everybody was given a fair opportunity on the exam. I think that's about it. Are there questions?
There were one question about how the faculty checks the contact.
Okay.
Proximal contact.
So basically, this has been an issue for many, many years, and it's a visual inspection. Okay, so you could conceivably have, depending upon the thickness of the floss that you're using, you could have some resistance to the floss, but it could still be visually open. And when you're inspecting the contact yourself, you need to look at it from more than one angle to be sure that no matter what, no light passes through. And if you really want to check it, you can take the transilluminator and come in from the facial and hold your mirror on the lingual and change the orientation of your mirror and see that the light is interrupted. But it is not sufficient to say that the floss has some resistance and therefore I have a contact. There's a visual inspection. And in the past, we've used thin paper to see if that would be resist, but really the best way is the visual inspection. Sometimes we have that may be one where one faculty will say one thing, the other will say another. We may have to have the tiebreaker there.
All right, another question. When we leave the cubicle, so if the faculty comes to do the evaluation, you have to leave the cubicle, but you don't have to leave the clinic. So you can maintain your PPE, you don't have to remove them. Okay, but just go far enough that, or let's go by the dispensary or something within the same area, not on the other side if you're on the blue side or if you're in the red side. So you don't need to remove your PPE for this, I assume, right?
Yeah. Correct. I would just say a couple things to remember. Okay, make sure you use rubber dam isolation throughout the examination. The only time you would remove the rubber dam is when you're checking the occlusion at the very, very end. Okay, and also while there's a lot of aspects of this exam relative to time limitations, I think particularly with us coming to your cubicle rather than transporting the patient over to the evaluation area has been done in the past, I think that time really isn't a critical part of this examination. And I would just urge everybody at every one of these critical steps, say before you're ready to send the patient over for the preparation check, if you're uncertain, why don't you walk away for a minute, collect yourself, and then look at it again with fresh eyes. I don't think that time is that critical that if you took another minute or two and looked at it again after you stepped away for a moment, I think that would give you a pretty good idea. I might use the same thing and step away for a minute or two. If you have to ask for modifications, then go back and read the request you've made. Does that make sense? Is that where the caries is? Is that where there's still some irregularity in the dentin that I need to make adjustment for?
A couple of questions, Dr. Markowski. One of them was, we have an ML and a DL. Please, guys, you need to make a decision. You cannot flip-flop before you come in, number one. Number two says, how many teeth are supposed to be under the rubber dam, Dr. Markowski?
Well, that's a decision that the individual student would make. I would think that you would isolate at least minimally at least one tooth on either side of the tooth you're preparing.
The thing is, you can get a good isolation and not as much of a leakage with the liquid if you have at least two teeth on either side. The other thing it says, Emily is asking, are we going to have a mock competency for what our actual CDCA exam will be like? We're not going to have another mock competency for a typodont tooth. I'm sorry, you guys.
Yeah, they're using the Confidant tooth now, and I don't know how many different versions there are. That the caries, seems very, very much like what what caries feels like in a natural tooth. I don't know how much variation there is. If someone,
but in terms of process, I want to let them know we do not want to have the patients walk around with the rubber dam hanging out and sitting in a row. So they're sitting in a chair. What they're going to do with a typodont tooth, whether they're going to come and look at it when it's in your chair, or whether you have to actually, carry the typodont with the head and everything to them, that I don't know. That's something they're going to tell you. But definitely for the patient, we're not going to have them move around. But the typodont, they're going to tell you whether they're going to do it in the chair or they want to bring it to the examination station. And that's something they're going to tell you.
The ideal prep criteria dimensions, that's something that we use every day, daily evaluation form and competency form. Those criteria forms are basically in your website, on the course website under the competency and forms, and go to restorative section. You can pull up all the class 2 and class 3 criteria. They're already in there. And technically, if you have done enough number of restorations, you should know those by now. And then the other things, if I don't have a patient, should we still come in? If you don't show up for this exam, this is your competency, and it's technically failure. It's like you're not going to the CDCA exam, or your patient doesn't show up. Technically, you failed that exam. But putting that aside, I want to make sure that I'm talking about the people who had enough experience in restorative dentistry. In other words, if you have done enough restorations, you qualify for exam. So this is a timed competency exam. It's like not showing up to a didactic exam. You will technically fail the exam, and then most likely you'll have to retake it, because we cannot close the clinics and redo this. So you have to take it on the floor, but the highest you would get would be 70 in that case. I just want to make sure that this is a mandatory exam as states in your syllabus, then you have to show up for it.
Right.
And go ahead.
When the current says the highest you're going to get in 70s, means you've actually failed the first one. So heads up on that. The other one said, are we going to get type competency? We are getting a caries tooth, the front anterior tooth that has caries, and a molar. I think we got number 19. It's not the same tooth that they use for the test, but it's very similar to it. So every student get, again, one anterior tooth and one posterior teeth, and you're welcome to go upstairs, get any teeth that you want to practice on that don't have any caries. But I was able to secure one anterior and one posterior tooth for every student that we have.
You got to write your progress notes, basically just like usual, and approve them once the procedure is C-coded. And then the patient, as I think it was discussed, is free for the patient. And Dr. Saunders' office was saying that they will be taken care of. Technically, you don't have to take them to the financial area, but we're going to follow up the list. That's what we were told.
I'm going to find out if the teeth are here that were supposed to be here January. So I'm going to find out if they're here. As soon as I know, you guys can go and pick them up and keep them. And the practice situation for those teeth is going to be just like we did before with the bridge that you could use between the cubicles, but only a certain number of students are going to show up. Not every single cubicle is going to be filled up. So that way you can get some practice time too. Before you can take it. And as Dr. Goran mentioned, are the people that have actually passed this competency are going to be the one eligible to go and take the CDCA. So that is going to be how it's going to go. So that way you know that you need to practice. I mean, you need to practice anytime you want. That's not an issue. But I'm going to find out about the teams if they're ready for you.
The modification form will be on the course website. I'll send you guys an announcement so that you know how to access it.
The days for the CDCA, Dr. Saunders has them. I know we have two. We have secured them on a Saturday and Sunday, and there are two that are pending. But Dr. Saunders would be sending those out. I don't have that at my fingertip. Carrie may have the first two. I don't have them with me.
We gotta check with Cheryl, I think.
They're in February. They're in February sometime.
The academic calendar. So if you go to dental.udmercy.edu and then just put in academic calendar, you should be
it's on the calendar. Yeah.
Can we have gloves on the clinic floor? Can we have more than 2 pairs of gloves at a time so that we don't waste time getting more gloves? I think there should be some gloves, but let me check with Saunders on that. I mean, they're not going to be wasting too much time. Again, you have 7 hours to do 2 restorations, and I understand that you don't want to waste your time, but probably the gloves is going to be the minimum amount of time you would be wasting on. But we'll see what we can do. We may come up with some additional boxes close by. We're going to have some faculty. And also the other thing will be infection control as part of the exam. So technically anybody can fail because of that reason. And I know we discussed all the faculty, including the perio faculty who will be walking around, is going to make sure that the infection control measures are followed up. So be careful about that.
Okay.
The other thing is I'm gonna have a little snack for you guys in the special function room. You have to come up and get it. You can only come up and get it, go out. I'm not sure where you're gonna eat them, but just in case.
Very good.
We don't want you to pass out.
Yeah.
Have them for the D4s and the D3s.
All right.
Okay. Any other questions? If you missed anything, you can still text. And me and Dr. Bajani will be around. Dr. Stewart will be around too. If you have more questions,
Yeah.
you can catch
Dr.
us tomorrow.
Stewart, can you use that light to see if there's any composite left? I didn't think that was an issue.
Yeah, I don't think that should be an issue.
No, that's
Right.
all
It's
right.
not on the CDCA exam. And if you want, not that we have a lot of experience with this, but the CDCA exam says you can even use Carey's indicator as long as it's not red.
I wouldn't recommend that one.
No, I'm just saying, I wouldn't either. But I'm just
It's
saying
same
that
everything.
anything that you could honestly use in your office, including a patient, you could use during this.
But the light is pretty safe and it's actually pretty good.
Yeah.
I saw some students have them.
And you want to be careful because you do not want to leave. You don't want to send in requesting a prep check when you have remaining existing composite. That would
I
also
think
be.
the other thing is I think they're gonna put some tables out. I'm gonna find out from Dr. Saunders what's gonna be on the tables for you guys, okay?
We can actually put some glow boxes on those tables too.
Right, that's what I'm thinking.
Do
So
that.
I'm that gloss is not going to be a major issue.
Right.
Anything
Okay.
else? All right, let us know and good luck.
Good luck.
Start from Wednesday to Friday.
Yep.
Okay.
All right.
All right. It went well.
Anybody have any questions?
Looks like we are good.